for quite a while, taught me psychotherapy when I was a resident. And it's Dr. Alan Abbas, and he is a professor in the Department of Psychiatry and director of the Center for Emotions and Health. And he'll be presenting today on treatment, non-response, and psychiatric disorders considered unresolved attachment trauma. So welcome, Alan.
Thanks very much. So welcome to everyone. A couple of the main points we're going to talk about here is one is that non-remission is a very common outcome in psychiatric care, and attachment trauma and its impact on treatment and healthcare providers is sort of an under-recognized and under-addressed issue. Tailored psychiatric treatment requires attention to emotional relational processes to achieve remission. So it's to speak about remission and some of the factors that make remission a challenge in mental health care, and an approach to one component of this, which is underlying emotional processes related to previous relationships and how that impacts and can interrupt treatment remission and treatment effectiveness, regardless of the model, regardless of whether it's psychotherapy or medication treatment or group management or anything else. These factors bear on outcome. So non-remission appears to be the most likely outcome in psychiatric care. If you take a look here at long-term studies of serious mental illness, less than half of people will remit. And remission is movement to a healthy state. This is antidepressant treatment, this large STAR-D study in depression. In the first line of treatment, only 1 in 6 people remitted. 3 out of 10 remitted the next one. When it comes to the second, third, fourth levels, the remission rates go lower and lower as people have failed previous treatments. And the issues of this are huge. We have conditions that are very damaging to people and to society and to families that often or most of the time are not getting resolved in treatment. So this is the large database from England using psychotherapeutic services. Less than half of people going in for first-line treatment remit or recover. So that means the majority of people are not recovered after the courses of these treatments here. And one of the factors, what factors bear on low remission rates? One of them is comorbid personality difficulties, in which is interpersonal patterns of relating to self and others, that impacts on these low remission rates. So what are some sources of treatment resistance? First is biological factors. You can think of anything from genetics to medications to substance effects to head injury and medical illnesses. You can think of social, familial, environmental factors. For example, with COVID and a study that we did here with Sherry Stewart and Simon Sherry and others, there's a lot of increased mental illness just around the COVID situation with home study and restrictions. So external factors and such, and family factors. And psychological factors, you can think of cognitive, behavioral, interpersonal, and dynamic factors can be important. And you can get an interplay between these ones, going back and forth between these factors, and you can get other things that are outside of these factors. So in order for treatments to be effective, psychological components of resistance have to be identified and addressed. And one major source that we're going to talk about is unresolved attachment trauma that gets activated in the treatment relationship. So attachment trauma is either failure to form a secure attachment or ruptures to a secure attachment. So for example, an example of ruptures are the death of a parent, broken home situation, disrupted relationships from that, or neglect or abuse that comes from a care provider. That causes a lot of strong emotions in the kid going through these disruptions, including grief, disappointed love and bond efforts, rage and guilt about the rage. So all these mixed feelings there become buried and avoided. And you see the kid become frozen emotionally, body dysregulation of the nervous system, and development can be interrupted, social development, and self-care becomes interrupted. So what happens then is when the person enters the system, you see they're making a new bond with the therapist, the treaters, or the physicians, whoever it is. That activates mixed feelings about the past relationships. And that activates and shows up in specific ways in the forms of unconscious anxiety with body manifestations of unconscious anxiety. And that anxiety activates avoidant habits that are built to reduce the anxiety. These are also diagnosable specific formats. The end result of these mixed feelings, including this guilt, is that the person unwittingly sets the stage for failure of treatment, and also sometimes inadvertently behaves in ways to undermine the therapist and undermine himself, undermine the other person. So the relationship gets interrupted, symptoms can get worse or both, and then you see a treatment-resistant outcome, and it has a bad effect on both the patients and the treaters. It can lead to more hopelessness, increased suicidality eventually, where the person keeps failing treatments. Now, on top of all this, we're talking about a patient response here, but as people, as humans, parallel processes like this can happen in the treaters. And this also, if the same sequence happens in the therapist, it can have a bad effect on the therapist and the patient. So it's something that is something important to know about when it comes to providing mental health care in the same way as, neurosurgeons have to be dexterous. They have to know what their limits are. They have to know the anatomy, the physiology. When they're going to do neurosurgery, they have to know then when they're having a bad day, they call someone else in. When they get tired, they actually call someone else into the OR to take over. They need to know their limits and need to know what they can do and how they can operate as an instrument. It's the same goes for us. So I'm going to talk now about 3 categories of this resistance that comes from attachment trauma. So the first we just it's referred to as highly resistant or high resistance. So this manifests as voluntary muscle tension, where the person has tension going from the top of the body down. In a seated patient, you see hand clenching and sighing respirations. Clinically, this is seen often with somatic problems of stiffness, tension, tremors, pains and aches, hyperventilation phenomenon from the repeated sighing, chest pain, shortness of breath, and panic. When a person has this pattern, they tend to be able to intellectualize about emotions, but have trouble to feel any emotions. And they use habitual avoidant behaviors that we refer to as character defenses, like passivity, defiance, compliance, going helpless, as habits to cut their anxiety down. And this here patterns we see clinically related to unresolved complex feelings about past attachment trauma. Complex feelings means grief, rage, and guilt about the rage, all mixed feelings getting activated, manifesting in the office in this format. So what do you see then as far as clinically? Is that the person unwittingly, without planning to do it, becomes tense and defended and interact with the therapist in a way that doesn't allow therapy to proceed in a collaborative way. And I'm talking therapy as in any therapy, medication therapy, supportive therapy, cognitive behavioral therapy, group therapy. The patterns that automatically show up is a person will avoid engaging with the therapist, or if it's group, and avoid engaging with others in the group. Defiance, where they resist and defend and block, becoming overly pleasant and compliant, becoming passive and helpless, becoming critical of the therapist, becoming distant or sarcastic. Now think about it as that these patterns here, when you're the therapist and the patient is responding these ways, we're all going to have a natural tendency to respond to these in certain ways. So this is a kind of responses you can see from the therapist. Is the therapist can start getting avoidant, they can become over controlling and defiant toward the patient, they can become overly pleasant, overly, they can withdraw, neglect, become resigned, give up, want to end the treatment, become hostile and start arguing with the patient. So here, the other way to think about this is this process can happen in the patient, it can happen in a therapist, and it can go back and forth and escalate itself into a treatment stalemate and a situation that neither person wants to attend. So you can think about this is an attachment system getting activated. This is a therapist attachment system getting activated. Or you can think about it as responses to each other. Whatever way you think about it, it's a real problem trying to collaborate and do any kind of treatment. So that's category one. The second here is patients who have repression of emotions, where the emotions don't reach consciousness. They get activated, but they don't reach the conscious part of the mind. So this patients will tend to have involuntary muscle anxiety and muscle weakness. So things like, you can see this activate things like migraine, irritable bowel, blood pressure problem, bladder spasm, muscular weakness, fatigue, and psychomotor retarded major depression. So the emotions they get activated, but they don't reach consciousness, or they dip in and out of consciousness. They're there for a second and then they're gone. And this relates to intense, complex feelings, typically earlier in development. And it's usually compounded by later abuse on top of the initial attachment trauma. So as far as what you see here clinically, then, you see a person who involuntarily gets shut down, self-critical, and undermine the treatment. So the patient patterns here tend to be more regressive phenomena, where the person becomes helpless, weepiness, self-attack, become angry at themselves, depression and suicidal ideation, and somatic symptoms like stomach upsets and other things happen. These things can happen right in the office setting. And then you can see therapist responses to these. These kind of patterns might pull the therapist into a rescuing position or a supportive position or a reassuring position, even though they're inside, they're getting frustrated. They go in, it's tendency to go into rescue mode or reassuring mode or support mode. And then the other response the therapist can have is become critical and angry at the patient, become pointed and harsh to the patient, or they can become depressed and hopeless as well. Or they can develop somatic symptoms. So this is the kind of situation that when the patient is on the list for the day, the therapist gets nauseated and anticipation of seeing the patient. And again, it's the same thing. This can go back and forth and escalate itself, whereby both people are doing various kind of patterns, both of which activate the other person to have negative effects. And it leads to a treatment stalemate or bad outcome. Now, the third category is the fragile kind of pattern where the person is, you can think of them as scared and confused. So this pattern, the person has anxiety in the form of cognitive perceptual disruption with mental confusion, losing the senses, the visual and auditory systems not working, vision blurring, hearing getting distorted, have pseudo seizures, loss of consciousness, dissociation, and can hallucinate from anxiety. You see this with primitive defenses where the person projects parts of themselves out onto others and splitting into black and white, for example, into all good, all bad. So there's distortion of reality and there's distortion of the senses. So these individuals can have pre-psychotic episodes, paranoid and borderline personality, and dissociative disorders. And this relates to very early attachment trauma in infancy, whereby the parents tend to have a pattern of scaring the baby and not being a secure base. Parents tend to project hostility onto the baby, even the little one, and then have a negative reaction to the baby. And then that goes on to the person is constantly in this fear state, this agitated state, this self-loathing state. And so it's a bad situation here. And this is more severe mental illness can be manifest as a product of this directly. So what kind of patterns you see here then is the patient doing these things with this distortion of things, getting confusion and all this sensory issues, getting self-critical and angry at themselves, getting depression and suicidal ideation as well, and somatic symptoms of different types. So there's some similarities. The pull when these things are happening is that it pulls the therapist toward rescuing or idealizing, which can easily flip to devaluing. The boundaries might get blurred. When there's boundary problems with professional to patient, it's often in this category of patients. The therapist can also become confused and get cognitive disruption, can become depressed and hopeless and develop somatic symptoms, all these same things. And again, you can see this escalating process. So I hope you get the sense of what these kind of challenges this poses if you want to just prescribe a medication. This happens when you're doing a prescribing 15-minute interview. All these things can happen. And so you can imagine that these patients that have stuck with these patterns, they're not going to tend to respond to any treatment that doesn't address this process and doesn't address within the clinician what's going on and how that bears on their interaction with the patient. So looking at these categories, you can put them along a continuum here. You have this repression group, you have high resistance. And at the other end here, you have these groups here, which are relatively healthy individuals with good attachment histories, with secure attachment mostly, okay? So these patients do exist out there that haven't had a big attachment trauma. We just don't see very many of them. So here's the situation in a study that I did in outpatients, and this is in West Vancouver, office practice as a psychiatrist. So you can think of it as secondary level care. 4% were low or moderate resistant, 10% moderate, 35 high resistant, 25 were repression, and 25 were fragile. On a ward here, this is the way the numbers look though, on inpatients. You have like no low resistant patients. You have relatively few high resistant patients. It's mostly all repression and fragility. So you can think here then, where's the remission? The risk of non-remission is all this group here. If you start adding it together in outpatient practice, there's a significant portion of psychiatric referred patients are unlikely to remit unless these processes are addressed. And inpatients, very unlikely to remit unless these processes get addressed somehow. So I'm going to present a case. So this is not going to be video, but it's a description of case material. 55-year-old married man with chronic depression, dysthymic disorder. He had an active pattern of self-hatred, disgust for self, a sort of self-declared loser, social anxiety disorder, paranoid personality, borderline personality diagnosis, generalized anxiety disorder as well. Variety of somatic symptoms, dizziness, jaw pain, stomach symptoms, and other problems, recurrent work loss, and long disabilities on mental health restriction. He had a lot also of impulsivity, irritability, would break some things, had trouble controlling the temper. He had a past suicide attempt and prolonged hospitalization. He had a shocking number of previous medication trials and psychotherapy trials over a 35-year history of involvement with mental health. So a highly refractory person. So here's the patterns that we saw. He had past severe criticism and rejection from father and with a passive mother, craving of attachment, grief, intense painful feelings, and intense rage about this pain, and guilt about the rage as a kid, and all that's buried. And all that guilt turned into chronic expectation of criticism from others, including the health professionals. So it became natural to expect the same treatment from others. And all those same emotions keep getting mobilized. The end result, though, was a chronic shame and self-loathing and worsening whenever he got into treatment, inability to collaborate and succeed with others, which led to more medication, more psychotherapy trials without benefit, and dropouts. Oops. And leaving him in a persistent state of despair, self-hatred, perceived judgment, wish to be dead, to unburden the family. He talked about a zero social life, and was placed often on recurrent disabilities, on long-term disability. So what do we see in the office then? So positive feelings is his first move. His first response is something, hoping for something good. And that stirred old pain. And that stirred old rage and guilt about the criticism from the father. This is coming up right away. And these gets projected onto the therapist. He perceives or expects the therapist to be critical, which then mobilizes rage and guilt about rage towards the therapist. That goes back into self-hatred and shame on himself. He then moves to expect or even encourage the therapist to shame him, and becomes agitated towards the therapist and self-critical and hopeless at the same time. So it's a triple thing going on. It's self-criticism, it's irritation with the perceived critic, and it's his hopelessness at the same time. It's alternating between these different patterns. And all of this, okay, occurred in the first 5 minutes of contact. So you have multiple things going on under the surface, almost hard to visualize in those first 5 minutes. And for him, he's used to doing it, but not used to thinking about what's happening. And the other thing that can happen is, this is the same process that in likelihood occurred with all his other contacts going back the last 35 years. All of this sequence, so the note says, pleasant patient, constant self-loathing, very depressed, more medication, more therapy referral. But what you have here is all this stuff happening under the surface. So this is the type of cycle that we saw that he has. This inner cycle here is, think of this as a loop that can start anywhere you like. It starts with a projecting of the critic, fear of the critic, rage toward the critic, guilt about the rage towards the critic, which turns into more projection, which turns into more fear, which turns into more rage, which turns into more guilt, which turns into more projection, fear, rage, guilt. This can spin around and around. And at some points, he'd be stuck in the projection. Some points he'd be stuck in the fear. Sometimes he's stuck in the irritability. Or he spins out of the cycle and goes into this avoidance and dropout and just disappear and die kind of thing. Or he flipped into this shame place in this depressed, exhausted state of self-loathing. So this cycle can spin, he can go out into the shame. And this all can happen in minutes. And he can do it without a person even there. This is a sort of a cycle. It's a cognitive behavioral cycle with emotional activation in it, if you think of it this way. And so he can be stuck here. He can be stuck in this projective thing. He can be stuck in fear. He can and then be avoiding, dropping out, or irritability. So treatment-wise, we got all these things then that we saw here. So what are you going to do as a clinician when this is happening? So first piece is to recognize there's a positive attachment drive and a positive feeling coming up with you, the therapist. Help them identify and recognize these cycles and emotions. And help them observe what's going on in these minutes, these like 1, 2, 3 minutes. At the same time, you're going to have to help him regulate anxiety and calm his mind and body down so he can observe what's going on, because the anxiety was causing confusion. It was causing him to be agitated and uncomfortable. So had to regulate anxiety with some specific approaches. Just notice the body, notice head to toe what's going on. Kind of grounding approach can work. Help him just regulate his own thought process by observing it. And you, clinician, behave in a non-judgmental way, just noticing things and helping him notice. What gradually starts to happen then is he's going to start to identify and feel mixed feelings that come up with you, the therapist. And eventually these become linked to these past events. So it's identifying observing, regulating anxiety, helping identify and start to feel emotions. And what the sequence goes, and this is pretty typical, he first starts to have a capacity to feel grief for himself, okay? Second, he starts to be able to tolerate the awareness of anger or rage in the body, which is like a heat energy. It doesn't do anything, it's just sitting in his body, but it wants to do something, but he pushes it back down. And finally, when he has more capacity to feel guilt about the rage and empathy for the person he has rage towards, that typically starts to occur first with people in the current life or the therapist, to be able to tolerate the awareness of mixed feelings. Next is this improves his anxiety tolerance, improves his ability to calm himself, improves his ability to validate his own emotions and to hold the mixed feelings together. And what happens is he ends up gradually reaching a state of empathy for the father after he worked through some of the rage and guilt, realizing the father was a damaged kid and that the father had a lot of difficulties. And that on its own, the feeling of this empathy for the father and realizing he had these mixed feelings, including guilt, it helped him undo this need to be self-punishing and to expect punishment. And in his own words, he said he began to realize he was a loving, worthy person. So it shifted the whole thing around. So here's basically what happens. You see, you have this whole cycle going on. By identifying and recognizing and starting to feel that there's guilt about rage, that he has caring for people. It's not just a rage situation, he cares. That basically breaks the cycle. You see, so now he can't go to projection anymore and he can't go to shame anymore because he's a loving person who cares. And it also, that breaks the fear cycle and that cuts down on all this. So basically the recognition of him being a caring person who developed a system to protect people from the rage that was caused by them hurting him is huge for this guy. So this is what ends up. I'm just realizing that when I don't have video, the talk goes a lot faster. So at termination, session 15, so mood is much more normal, anxiety much less, more stable with the family, assertive, more confident. Self-caring replaces the self-hatred, more socialization with less anxiety, made a return to work. He had had a restriction at work where he couldn't do certain things for years, and that got removed. So he was doing work, full work in the whole zone of his work without a restriction. PHQ is a depression measure. This is severe depression to start with and down to 6 at the end. So there's a remission on self-reported depression. And this here is the inventory of interpersonal problems. This relates to his, it's a reflection of personality patterns. And you can see here he had a lot of self-sacrificing, over-accommodating, passivity, social avoidance, and this has to do with his projections, coldness and detachment. Vindictiveness refers to a sort of sense of a wish to punish others in a sense, and domineering is what it sounds like. Blue is the norm. So he was way out on all these scales. Now that's before treatment. Here's after treatment. Those are all under the norm. This is at the norm. These are basically all normal. There's a little bit of coldness and social inhibition. So this here response where he gets close to or within the norm is a really good predictor of sustained remission. It's better than symptom reduction for a predictor of sustained remission. So this is just some of his own words. He says about work and social. I've done remarkably well with my return to work, been there 3 months. It can be a very social job depending where you work. I'm back there, and because of I'm sort of more of an acceptance of who I am, what life is, I'm working in these larger groups of people. I do have moments of anxiety or whatever, but it's far less than I would have anticipated. So that's pretty good. View of himself. It's a lot better. I try a lot to stay in the moment, not worry about what's going to happen a minute from now, or an hour from now, or a day from now, or tomorrow, or whatever. And that's really helpful. Not only have I always feared judgment from others, but I was very harshly self-judgmental of myself, trying not to be so harsh on myself, Just as I'm trying to accept that whatever happens, happens, I'm also trying to accept that I am who I am. Some people can like me and some people might not like me. That might sound like an obvious thing to you to realize these things, but that's not the way this guy's lived for 55 years. And he had multiple trials of cognitive approaches, but why didn't they not stick? Well, you can imagine that if he's flooded with anxiety, he can't use his mind to do cognitive work. When the mind is calm enough and the anxiety is down, he can then fix his own thought patterns, essentially. He can use cognitive techniques now, see? And change and correct his own cognitive distortions, as well as his own behavioral avoidance. So I like to think that this kind of work on the emotion part enables cognitive behavioral processes to be helpful. This is just about impulsivity. I haven't been really angry for a few months. If I drop a hammer on my toe or something, before I'd scream and curse and pick up the hammer and throw it against the wall, now I just tend to pick up the hammer off the floor and maybe know my toe hurts. Don't swear or curse or fly off the handle. I just pick it up, continue with what I was doing. It's not 100% natural, but I just make the decision in my head that there's no point in flying off the handle over an accident. Sounds reasonable. It's reasonable for him at this point, but before he understood this and worked through this, for him, he would self-attack so severely for every accident, anything he would make a mistake. He'd be so self-punitive and so aggressive that he would break stuff. That is all diminished. See, there's a whole difference. There's other quotes where he talks about the difference in his feeling about his father and understanding of the father. And that's translated a lot to him as a father. So what is it required of the therapist to do this kind of relatively complicated therapy process? We have to be able to tolerate positive feelings. That might sound like obvious, but it's not necessarily that easy to sit and absorb a patient's positive feeling with you and realize that that's going to activate everything else behind it. Be able to identify this processes as projections of the critic while not being a critic. So to observe things without doing them, to observe that there is projection without being part of the projection. Be able to tolerate anxiety and help the patient do the same. Be able to, this is one of the bigger ones, be able to feel emotions in our own body, including anger, without acting on it, but just use it as a gauge that what's happening in the patient and what the process is. To be able to feel your feelings, to use it as a tracking method for the patient's process. Welcome all the feelings that come up towards you, the therapist, realizing that a lot of them are transferred from the past and some of them are transferred from current people and some of them are with you on its own. Be comfortable with all these things about the trauma. This trauma stories can be horrendous. It's just getting used to this, getting desensitized to that, and realizing you're going to have feelings about the patient's trauma too, and just accept that that is what it is too. And be able to feel some of those trauma-related emotions without defending, without going self-critical, without going depressed, without becoming sick ourselves. So we got to have our own way, our own system of bolstering ourselves and building our capacities, supporting one another. Video is a huge way to do that, where you get your self-reflective time after a session to look at what's happened. Use the video to do peer review, to work with a mentor, supervisors as well, and to have a group. I'm going to mention it twice because to me, the more complex the patient is, the more we should not be working on our own. We should have a group, someone to talk to about the process and to get opinions and input as well. Now, all these things that we've talked about, I've talked about it with the person with personality disorders and anxiety disorder, and he had an eating disorder and he had ADHD diagnosis and he had substance in the past too, and he had somatic problems, but he didn't have psychosis or bipolar disorder. He had depression. So he had all these things. But the point here with this diagram is that all of these conditions, you can see fragility, repression, resistance, or even lower resistance in some cases. And you want to look at remission rates. This here is a lot more important than the diagnosis. this is going to be important to address with all the patients as much as you can, to give them the best chance of remission and to make it so that the process with you is not going to be exhausting you, and it's going to be gratifying for the patient and you. Some good collaborative process where some of this gets corrected, or at least recognized. So it sort of goes back to, Lara says, I've been at this a while. It's like 30 years now since I got exposed to this psychotherapy at McGill. And it's a Canadian developed model that we use that's practiced worldwide. It's designed to detect and repair alliance ruptures. Okay, this is what we're talking about, alliance rupture and repair here. There's over 40 randomized trials, 25 cost-based studies, 25 process studies. It's a well-researched model, and the training is all video-based. And each case is a single case study, because this is not a panacea. This is not a treatment that's effective for everyone. It doesn't solve all problems. It doesn't solve biological and social difficulties. It can help in some of those things, and it can help some people resolve their problems mostly completely. But it's a contributing factor that you're addressing here. And you just got to try and do your best, and the patient does their best. And in a lot of cases, it's helpful, but it's not always helpful. You just give it a go, use video, get peer support in some way, and just do your best. And over time, the clinical capacity we have goes up over time. And it has built-in supportive formats. And this is something that people don't know about this method. This isn't a hammer and everything's a nail. This is a model that in the real world is mostly supportive and capacity building first, and then the emotional processing. It's only for a minority of patients who are highly defended do we need to do heavy interventions to really help them to challenge and go against their defenses. Most of the majority of the patients, it's a supportive capacity building format. And because it's got all the different formats in it, it's useful for about 5 of 6 psychiatric referred patients, which is, quite a large portion. There's over 30 studies of complex patients, and they tend to show high remission rates. So a personality disorder study we did, 86% remission. Pilot we did with mood disorders and treatment-resistant depression, TRD, 80% remitted. Study in Norway of a treatment-resistant sample, 64 remitted on personality disorder. An addiction study we did, a randomized trial. This is a very ill group, 21% had psychosis, 26% had antisocial disorder, had a 49% remission at 6 months. And UK, there's two studies out of the UK showing 80% response rates at tier 4. This is our treatment-resistant depression study led by Joel Town. This group was very ill. 90% of personality disorder, 90% of medical illness. Half of them had this fragility, 16 treatment sessions, and most of the patients in our treatment arm stopped or reduced their meds. The community mental health team, care as usual, including psychotherapy, most of them increased or started medications and had some cognitive behavioral therapy. You can see here the remission rate at 6 months in the first paper was 36%, compared to the team was 3.7%. So it's a 10 times more remission in the early phase here. And the ISTDP was more cost effective in follow-up. So these are just a few of these 30 plus studies of refractory patients. This is for psychotic patients. As you can think of this as tier 4 care. This is their physician and hospital use. It goes down into the normal range and it persists in long-term follow-up after 13 sessions. These patients had paranoid ideation cut in half. So they were refractory with leftover paranoia, psychotic phenomena, and interpersonal gains as well. So on terms of their interpersonal patterns, this is an averaged figure. They tended towards the cold inhibited. This is through the continuing paranoia here. Looks like this, and also some passivity tendencies. And after treatment, this all reduced. And again, this is the better predictor of long-term remission and not falling back into hospitalization and such. Same for bipolar. The data was really similar on hospital and doctor cost reduction. Their symptoms and interpersonal problems reduced at had large effect sizes. This is their interpersonal patterns on average. They had more this depressive side here, which is passive, self-sacrificing and overly complying. And they also had this more cold style that sort of referred to more the projection and fear responses. So that's before and that's after. It's really normal on average. Again, everyone doesn't respond, but it's on average, they improved a lot and they had huge drops in healthcare costs and use. This is tier 5 on inpatients. Psychosis, we had all kinds of patients on the ward. Their symptoms improved. There was some interpersonal reduction. This is the key finding here, is that 65% drop in electroconvulsive therapy on the whole ward. The reduction recovered the treatment cost of the psychologist. So this is in the system cost reduction by reducing ECT, by using this approach with inpatients to augment care on the ward. This doesn't replace care on the ward. It's an augmenter to help them be able to relate, engage, and do better on the MAU approaches and other modalities used on inpatients. So one question that comes is, can therapists learn this approach? There's a number of studies that point that way. Resident treated cases make significant gains in one study. The amount of training related to cost reduction in a psychiatry resident group. So the more residents had training, the more their healthcare cost reduction was in follow-up in their patients. The other is we studied 57 therapists and found that expert outcomes were better than trained clinician outcomes were better than trainees. So there's a better outcome with more training. And there's another recent study around anxiety reduction and personality changes in new trainees in Italy. So what are the implications then? With resistant patients, treatment models that don't address attachment trauma are unlikely to lead to remission. Therapists are at a risk of burnout and other adverse effects with these working with refractory patients. I mean, none of us went in the profession to have patients not recover and not get better. It's discouraging to the therapist when there are things happening that and the patients aren't improving over time. Augmenting existing clinician skills to work with these patterns can benefit patients, therapists, and the system. So the point here is not that everyone needs to be converted into some certain specific treatment model, but knowing about some of these things and bringing it into your practice to at least detect resistance and detect when it's likely going to be a major problem to try to do, say, a packaged behavioral model or something. You want to know that up front and see what else can help. And resistant risk should be picked up on screening interviews. In other words, when people have an intake, this should be assessed. So we know what we're dealing with and we don't slot them into services that are unlikely to be helpful. We want to think about when using medications is appropriate, because based on these patterns as well. And again, just to say that all clinicians should have support when working with complex cases. So that the more complex, the more there should be clinical education support with peers or mentors. Okay, so that's basically it. We have plenty of time to talk about these things. So I'm just going to stop the screen share and see what we got. Any questions or comments anyone has? Excuse me.
That's great. Thanks, Alan. So there's a question or comment here from Nicole Hirschenhaus. You can probably see in the chat. Have you seen patients who appear to have fragile phenotype when acutely unwell, but then don't look that way on medication?
Very much so. So, for example, if a person has a head injury, is acutely intoxicated, is post-op, has delirium, their best defense structures are not working, and they're confused. They'll look like having the fragile pattern, and then it resolves once you address those issues. So that's a good example for that.
And maybe also just thinking about patients who maybe are having a depressive episode or hypomanic episode, they might look quite different as well, possibly.
Yeah, when a person's because I mean, I would take those as biological events taking place. There's certainly biological factors when a person's on mania. They're sleep deprived. They're having a variety of neurochemical processes in the picture. So some will look more fragile when they're in the midst of that state. Some do not. They're just mostly tense, and they're more tense and guarded. It's the same for some people when they have psychosis. Some of them are very tense and intellectual and guarded and defended, even though they're hallucinating. And other people, they're flooded with this sort of dissociative. They can't see, they can't hear. They're very confused. So there's different styles of response during acute episodes. So sometimes the anxiety is the presentation. Sometimes it clouds the presentation. There's a question about the length of a treatment session. The first interview is usually 2 to 3 hours in length. The sessions after that are usually an hour, unless they're coming from a distance, then it might be an hour and a half. The treatment length of the overall course of treatment is really variable depending on the capacity. So the low and moderate resistant patient, it's 10 meetings or less, or maybe a few meetings. The high resistant, you'd ideally like to have 20 to 40 meetings. Fragile group, symptom reduction can happen for a lot of them at 20 sessions, but ideally you'd have a couple of years, okay, for the more severely fragile with full-blown borderline disorder. Some can do, like you've seen with this person, can do well in 15 or 20 meetings. That's another question.
Yeah, I think you can see that there in the chat.
Okay.
Do you want, would you like me, Alan, to sort of read the questions through and summarize them for you as they come, or do you, that way you don't have to kind of be watching the chat or
I don't mind
reading the chat?
do you want you can read them, go ahead.
Just there's often a bunch of questions that come in one on top of each other, and I don't want you to be distracted from trying to think of your answers. So maybe with the question there from Nadine saying, wondering if you could explain how the transition happens from the patient experiencing positive feelings towards a therapist to activation of anger and fear, criticism, and so on. Wondering if that would play out in the first few minutes of the interaction.
So the first is the person's quite warm, friendly, looking forward to meet you, and then they immediately start to get very anxious. So for example, in a session with this person, as soon as he had this warm, positive moment, then the next second he thought I'm going to criticize him. It just comes into his mind that I'm now going to go to a critical position. In later sessions, when he had more anxiety tolerance, the positive feeling would come in about things going better. And then he would start to get tense. Then other feelings would come up right behind the positive feeling, including heat of anger and guilt about anger. And the next thing with that is he's with feelings coming up from his father. So when his tolerance was better, the feelings were coming up from the past. But at first, the defenses were operating, and he got this fear of criticism and self-shame and all that stuff I described that happened in 5 minutes. It's super fast. The patient can't see it. And unless we really slow down the film, it's hard to see. And this is really why we teach everything off video. Like when we do a course, and this person is going to be, I'm going to go through the whole treatment course on a 3-day course in a couple of weeks. It's going to be walking through those minute by minute processes to be able to see those things and to see how he changes physically over time, how the anxiety starts to manifest as strong muscles and ability to think straight. So it changes over time. So Rami's question.
Yeah, so he's wondering about use of ISTDP as an adjunct to CBT-based approaches.
So when you're using this approach for example, if it is, say, for example, a patient with PTSD, the capacity building piece paves the way for the later exposure, if you say the exposure and response prevention to the trauma itself. So the capacity building is first done in the room with us. And in current examples, by building that reflective capacity, we don't go to the trauma on its own until their capacity is up. Then it shows up on its own. Then they can bring it themselves, tolerate it, and then they can have a good experience going through that. So we're not so interested ourselves in getting to any content until their capacities comes. When their capacity is good, they'll bring it on their own. It shows up. So that's one way it's different. The other is there's a lot of cognitive work built into this here in the reflective work. There's also the parallel to training and relaxation happens in this model on the fly. When the person's confused, we do things to help them learn how to regulate anxiety. So those are a couple of parallels. And there's a ton of recapping, which is the same as behavioral chain analysis and review. We're doing a paper on the parallels between CBT and ISTDP, actually, with a person who's got a lot of expertise in CBT. So we're working on that now, and I'll be happy to share that when it comes out, because there's always a question.
Yeah, I have to say, as somebody who did training in ISTDP and then in cognitive therapy as well, I did find that ISTDP was useful for informing cognitive therapy for me. That I found it, I could see overlaps and benefits to having both perspectives. So yeah.
Oh, great.
So there's a question here from Shiloh. She says, I'm curious about how these concepts could be applied to a standard first assessment in the outpatient clinic, recognizing time constraints, focus on medication recommendations, and so forth.
Okay, so for how do you weave this into, say, an intake screen? First is observing. So you need to be in person, be able to see the person at least from the waist up, to be able to see body response of any of these anxiety patterns. Do they have tension? Do they get nauseated? Do they get confused? Just to observe that while you take your screening information. The other, though, you might have to probe for an example of when they get their symptoms and see how they respond to the probing question. Like, do they tense up? Do they get confused? Do they get nauseated? Or do they get weak? Or what happens? How do they respond? Do they get afraid? So with that focused part of the interview, you can determine, in most cases, within your screen as to where they are on that whole spectrum. And that can inform, you're thinking about medication, you're thinking about therapy modalities, you're thinking about, what. So if a person's heavily defended and guarded and not having much symptoms, you're not going to necessarily want to send them for work to try to change behavior. Because they're not going to have symptoms to work with. So anyway, there's different things to think about there as far as screening, but it's observation and focused interviewing will give you that information.
So when you're thinking about, like, let's say in the team-based approach of an outpatient clinic, so our community mental health clinic, like the ones that we have, how would you sort of see the different roles of people? Because a lot of patients have more than one clinician involved. How would you see that playing out?
It's a challenge when there's more than one clinician, and the more disturbed the patient is, the more there needs to be coordination between whoever's in the picture, and that includes sometimes the family physician. So family physician, psychiatrist, and if there's a social worker that they're involved within the public system, and then they also have a therapist. Some cross communication is important, so people are on the same page about interventions, what people are doing together, contributing to the person's benefit. So the more disturbed, the more the team needs to be aligned. That's one piece. That's probably the main piece. I would, a lot of time we can hold off on pharmacotherapy and try a first line treatment of some sort. Try a trial relational process of some kind and see what can happen if their symptoms don't settle on its own. So that would be my general inclination if someone's getting referred into the system. Video review with team, I think, is a great thing on Teams to be able to share your findings and get some input or just demonstrate what you're learning, share it with the team. Our way, everybody's in a learning, growing process. I mean, I still show video for peer input. I've been at this for 30 years. It's something we just do on a continual basis. It's part of the thing.
What about, do you ever have family members contacting you, or the patient wanting to involve family members? How do you handle that?
There's sometimes that people bring family in, particularly the more fragile people who are afraid. They come in with somebody because they're scared. They don't mind, they come in, and it seems to help with family members to understand the tolerance levels and the processes so that they can think about what they're doing and how they're impacting on their family members. So I think it helps them to watch some of the sessions. It doesn't happen that often, but it does sometimes. When it happens, it's fine. You know, it goes to, for example, family models for unexpressed emotion for psychosis and mood disorders. You know, what's it called? The you know, education and such on expressed emotions. The times I've done that, when I meet with family and the family's over involved and they're over concerned, and you got a young person with psychosis, I found that quite helpful for the patient. They seem to really thrive on that, and the parents appreciated seeing that there's something they can do to help make it less hard on the patient. So family interventions are huge for people that have more severe difficulties, no question.
So there's a couple more comments or questions here. Kathy Black says that she particularly enjoyed the focus on therapist clinician responses and the relevance to staff burnout. And she says, do you have any other comments to add to this?
Thanks, Kathy. I mean, it's, you know, it's, this is a very tough work we have. I think we're like neurosurgeons, whether we pick up a scalpel or don't, or whether we think we have scalpels or don't, we actually have scalpels in our hands. And we are working with people's open brains, in a sense. So that is very taxing on us in multiple ways. One is that it brings a lot of concern up in us for our patient. We have a lot of feelings for our patient. We have a lot of worries about our patients. And the story of the patient can bring up our own emotions about our own lives as well. Now, that's normal. We all have that happen. And as long as we can feel what we feel, we're fine. We'll even grow from that. We just don't want to get ourselves stuck where we can't feel anything anymore, get all numbed out and get physically unwell or exhausted. Now, team video showing and things like this, having education events, having some mentorship situation can protect against that. You know, it's just normal. We all have feelings. We're all people. We all have had events in life. Some of us have been less fortunate than others, but we all have had some things happen. And if we know about that, it's going to bolster us over a long career. Yeah, so, you know, we need to protect ourselves from burnout. We need to support one another through education and other things. I think that's appreciated in the system. It takes time. You know, a person is going to see one less patient a week or something to have that review period, but it's ultimately worth it over time. And
there's a question here. Alan mentioned outcomes being better with the more training therapists have had. What is a sensible expectation of outcome for a trainee therapist? And I'll be frank about this, and I know that Alan has heard me say before. I did some training as a resident with you, and then I stayed for another 1.5 years as a staff. And I have to say, I don't think I ever quite managed to master ISTDP. So,
well, one way to think about this is on a continuum, though. On the continuum, here's the outcomes are on a continuum. So if you have some focus on emotional processes, people's symptoms will go down over 5 to 10 meetings. If you have a focus on how emotions produce difficulties, that helps people. If they can identify and feel some of those emotions, it helps them more. If they can resolve a good chunk of those emotions that keep getting activated all the time, that helps them more again. But it's not a 0 and 100 thing. And the learning thing isn't also an all or none thing. It's sort of a gradually accruing more and more clinical competence and confidence through repeated efforts that you make with patients, self-review, video review, and those things, and sort of a continual gradual building of capacity over time. So a sensible outcome for the way I talk about it, if someone has supervision for 2 years, the average therapist can work comfortably with 1/4 of the referred patients to a psychiatric office. And that's a lot. You can have a full therapy practice as a psychiatrist and still do medical management and other things as well with that base of training, because there's a lot of people have moderate resistance and some repression that you can work with after a few years. Some people, it's way more than 1/4. So, and as I said, we published outcomes on 2 things with residents, and the outcomes were good on average. I mean, it doesn't mean every case, you know, it depends on who you get for a patient too. I mean, we try to have it set that your first patients are likely to be responders. The moderate resistant patient we try to have for residents if we can. so that you have a good experience, but we can't always get it happening.
Yeah. And as you said, there's a difference maybe between mastering ISTDP as an actual technique and having some knowledge that informs other aspects of your care, which I definitely feel I did get that from it. So,
Yeah.
so we're about at the end of our time. So thank you very much to Alan for, as always, an excellent presentation and lots of clinical relevance. And just reminders about some upcoming grand rounds next week on November 17th, University Rounds. Dr. Ron Postuma from McGill speaking on REM sleep behavior. And November 24th is the geriatric psychiatry rounds with Christelle Boudreau. So have a great week, everybody, and we'll see you next week. Thanks, Alan.
Thanks, Laura.
Bye now.